good day to all of you joining us for our second webinar on sepsis, Acute Care Part 2, and entitled with our lead speaker, Pragmatic Sepsis Care for Providers, Aligning Evidence, Guidelines, Mandates, and Policy to Inform Your Daily Practice. I'm Charles Denham. I'm on slide 2 for those that have not downloaded the slides. It's just a real pleasure to welcome you today. On slide 3 are those that have not downloaded the slides. Just make sure to turn your volume up on your speakers on your computer. And if you were to have a problem with them, on slide 4, we describe how you can request a phone button for a toll dial-in line, and it would be a better quality audio line if you need that. And that's on slide 4, going to the participants icon to do so. On slide 5, I address the landing page where you can go at safetyleaders.org, and in the upper right-hand quadrant of the landing page, if you click on the webinar, you can go there and for future resources or to download the slides. And it's just a great pleasure to have Dr. Jeanne Huddleston introducing our main speaker, Dr. Casey Clements, who will be our main speaker today. Their materials will be on the website so that if you click on that upper quadrant area, you'll land on the page that those of you that have the slides will see on slide 6, and we'll have future information there as well. On slide 7, the different addresses for Twitter and Facebook, etc., are on that slide, and I just want to refresh everyone and those that are new watching our program, this program today, that our purpose at TMIT is that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. So we include caregivers, and to quote MD Anderson, we have Dr. Boats with us today. We love the expression, for those we serve and those who serve. So it includes those as well. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. Slide 9 has our disclosure statement. However, there are no products or services that will be discussed today, so you can read that in detail. Our speakers and reactors include today Dr. Jeanne Huddleston, Dr. Casey Clements, Dr. Greg Boats, Dan Ford, and myself. And I see a typo there that our folks will fix on the slides with Dan Ford's name. What I'd like to do is just have Dan Ford open. We always have a patient advocate opening our webinars and to help us really focus on what's critically important. Dan has been a long-standing patient advocate. He's been one of our real leaders in healthcare and patient advocacy, and a healthcare insider from the standpoint of the recruitment area of recruiting CEOs and board members for our greatest organizations. Although retired from that, he's very, very active in working with hospitals on patient advisory committees, and he's a published author in patient safety, and he was one of the lead authors of the NQF Safe Practices that were focused, the Chapter 9 that was focused on engaging patients and families. And so, Dan, would you please open for us just to help us focus on our true north of the purpose of what we're doing today?
Yes. Thank you, Chuck. I want to welcome our outstanding faculty for this very serious subjects, and those who are participating in the audience via phone and electronically. Chuck, I want to commend TMIT in continuing to highlight sepsis as part of your long series of a number of patient safety issues. If I understand right, this is the 103rd webinar, which goes back over 8 years. Or over 9 years. I commend all those who are working diligently to identify, examine, and solve all related sepsis issues. I would identify this as a scary subject to all involved, and that's everybody who could potentially be involved. I want to thank you all for being here today, and I'll turn it back to you, Chuck.
Thanks very much. And Dan will also be a reactor on our reactor panel. Because Dr. Clements and Dr. Huddleston have such great content, and Dr. Boats, I'm sure, will share some great insights, I'm going to be very rapid in going through the quick news update and our webinar surveys from last month. I do want to remind you about the work that we are working on called MedTech, which is focusing on high-impact health hazards and the potential lifeline behaviors that can save lives. And Dr. Boat, we're just so pleased to have Dr. Boats, who's our faculty lead on this from MD Anderson, who's actually led the way on a number of the innovations in this program that now it turns out we've been approached globally to help take this globally. And the reason that I introduced this is that we've now graduated multiple classes at schools and are expanding to multiple areas of the country and working with faith-based organizations and also law enforcement and higher education. And what brings me to focus on that just as an introduction, and these are the 7 areas that we're focused on, and we've expanded from just bystander care in the first 10 minutes of an emergency through the pre-hospital communication with the professional first responders, but also helping families understand how they could play their part when they have a family member going through the emergency department, and this refers to things like the discharge return precautions and other things that are critical in patient safety. This graphic has been modified courtesy of formerly the IOM, but now the National Academy of Medicine. And Don Berwick was the chair of the trauma report that recently came out that used this graphic, and we love it. The reason that we're only going to cover one newsworthy item because we have such great content from Dr. Clements and Dr. Huddleston and Dr. Boats. But Dr. Boats, when we get to reacting, I'd love to give you some of the highlights of what you're seeing because you do work with the DEA, and Dr. Boats, you're also the medical director for the police department in Houston with Chief Bill Adcox. But this issue of these overdoses of opioids and the potential impact and the impact we're seeing of fentanyl and carfentanil, which Dr. Boats, you forecasted was we were going to have a problem, and it's just become a national crisis. And this picture that you see shows the amount of heroin, amount of fentanyl, and the amount of carfentanil that can cause a lethal overdose. And so what we've done is given you a number of references. I'm not going to read these slides. We've got 3 or 4 slides that have the news articles and also videos that you can use to help with the audiences that you're working with on this issue. But this is so potent that even police officers that are involved on an overdose scene or a drug bust who are exposed just to the powder of fentanyl or carfentanil have had respiratory depression and, in fact, have had to be treated for this problem. And we'll have Dr. Boats kind of mention this in the reactor portion. So we've given you a number of slides here. This is a national crisis with no seemingly end in sight. And one of the most recent things is that this is being ordered over the dark web. There was a prior website that was shut down that was dealing drugs on the dark web and using Bitcoin as the payment mechanism. And now there are multiple sites that have now come up since that was shut down. So it's almost this is a crisis with no end in sight, and we all need to be aware of it. We also need to be aware of the fact that drug diversion issues are growing as even our workforce in healthcare are subject to the temptation and the risk of this issue. So I'm not going to go through each one of these slides. Take a look at them, and they're good references for stories that can address this, and I'll have Dr. Boats also address this. But the picture that you saw there of the amount of fentanyl and carfentanil that is potentially lethal is just speaks volumes. You can have over 50,000 doses of fentanyl in a typical first-class envelope sent through the mail. So we know this is a big crisis. And Dr. Boats is much more of an expert on this than I am. I just want to shift gears to our polling question so that we can move rapidly to our speakers. And we asked the question after we covered some of the cyber harm and patient safety issues. We saw the ransomware things going on. And we asked you, I am interested in more detail on cyber harm and patient safety. And 24% of you gave it a 10, 64% agreed, and 24% very strongly agreed. Clearly, not as high as areas of medication management and sepsis and misdiagnosis, but there are a number of you that are interested in this, and we will be able to respond by putting more work together and inviting folks that are interested in this topic. So cyber harm and patient safety topics, we ask for a free text entry for you to put the topics that you'd like to have us cover, and you can look at this at your leisure. The second question we asked was, I am interested in medical record recovery post-cyber harm. So we know that one in three medical records will be breached in America. 1 in 5 of those will be contaminated by fraudsters who are seeking drugs, seeking payment, defrauding organizations. And 1 in 3 of those, that's 1 in 45. So if 1 in 3 breaches, 1 in 3 of the breaches result in fraud, that's 1 in 15. And 1 in 3 of those will end up with losing their health care insurance. We know the medical record recovery is a critical issue. We asked that question, and again, seeing some of you are interested in it. It didn't. It's strong enough for us to continue to work in this area, but clearly not in probably the top 10 topics that you would want to have covered. And the medical record recovery free text entry question was asked, and the topics are on slide 24. So that brings us to this issue about sepsis. So we had a terrific presentation last month on sepsis. It was part 1 of a 3-part series, and we asked, I am interested in more detail regarding sepsis. That's about as strong a response as we could have, as 63% of the audience was a very large audience, in I think north of 500 organizations. 63% gave it a 10, 18% a 9. So you're telling us that this is a critical area that we need to focus on, and we had a terrific presentation, and we're looking forward to that from Dr. Clements today. And we ask you, what are the specific topics that you would like us to cover? New changes, EMR triggers, decreasing antibiotic times. You can see, and I won't read the slide for you because I think Dr. Clements will be addressing that today, but you can see the topics that you gave us. And so very strong topic, very critically important. And so Dr. Jeanne Huddleston is a wonderful leader. Sometimes, when people push me, I say, listen, I think this may be the next Don Berwick. The work that she has done and with the folks there at the Mayo Clinic is absolutely terrific in mortality reviews. We've had Jeanne over the last year because of the demand. Every time Jeanne speaks, we get such high returns on please have her back, please have her address mortality reviews. And those of you that have not watched Jeanne, go on our website. She has given 3 long presentations and then multiple introductions, and in every one the net promoter scores were in the 90s and with more of a request. Jeanne is a hospitalist. Jeanne launched the program. She's the past president of their society, and Jeanne will tell you her background, but has been the lead on mortality reviews at the Mayo Clinic. And the work she's doing globally now in establishing a collaborative, which Mayo is a part of, is absolutely tremendous. And in my conversations yesterday with WHO, we're really promoting that this great work be actually shared on a more global basis out of Geneva, and we hope to see that happen. And Jeanne, please take it away from there.
Thank you very much for the opportunity to be with all of you. And Dr. Denham, I really hope you didn't jinx me this time. I appreciate your comments. You can't see me blush, but I sincerely appreciate your support and enthusiasm about this work. I have spent a lot of time speaking with many of you about mortality reviews and the collaborative, and I wanted to show you some of the results that have come out of the collaborative and sort of link those to some of the Mayo work and other things that we've spoken about in the past. And the delayed or misdiagnoses is a really, really big piece of that. And for those of you who haven't had a chance to hear me speak, I want to go through my disclosures and be completely honest with you. I am very biased by this work. I am an evangelist when it comes to mortality reviews and learning from the lives of our patients and the things that they experience under our care prior to their death or readmission or whatever issue it is that they suffer under our care. And so that does color my thoughts. I'm also a subject matter expert for Vizient and now the Mayo Clinic Care Network for mortality reviews, and I am the founder of the International Collaborative for the Safety Learning System that's supported both by Mayo Clinic and the HB Healthcare Safety, which is a social benefit corporation and nonprofit that was spun out of Mayo to start this work. And I am the volunteer CEO of that, and I take absolutely no remuneration whatsoever from any of that work or this work. We started Mortality Review because we wanted to learn more about what was under the water. And so have we been successful in doing that? I believe that we have. Again, that's a bias. But what we surprised us when we first started doing our learning was 80% of what we could do something about were omissions, not commissions. And when we look at those, a big one of them is sepsis. And this is a case of a 59-year-old female who underwent an elective total abdominal hysterectomy. She had 3 days of a worsening acute kidney injury, ileus, abdominal pain, eventually developed paroxysmal atrial fibrillation, and ultimately became hypotensive. We did not call her RRT for 3 consecutive days when she met our RRT criteria for that whole time. We did not start IV fluids or IV antibiotics. And when she finally died and had her autopsy, we identified that she had a nick in her small bowel and had a belly full of pus. So we had missed that surgical complication as well. This is an unfortunate 55-year-old man who underwent a bone marrow transplant, and he highlights his life preceding his death with us, highlighted 2 particular things for us. One, you can see here when he was dismissed from the hospital and came back in because he wasn't feeling well. And when he came back in, his pulse was slightly higher than his blood pressure, green line higher than the blue line. And there you can see, as a result, the shock index is positive. Well, we didn't quite act on that. And then when he finally met our RT criteria about 17 hours later or so, you can see there was an increased activity and that we charted his vital signs a little more frequently, but we didn't call the RRT. 17 hours go by again, and that dotted vertical line shows a clear mark where his physiological status changed. Yet it's 27 more hours before we called our RRT and he went to the ICU. Now, would he have died anyway? I don't know the answer to that question, but did we help seal his fate by not getting him the intensive care measurements, the fluids, the antibiotics, and everything that he needed when it was indicated? Absolutely. And so he represents to us both our delayed or misdiagnosis of sepsis as well as our inability to recognize and rescue deteriorating patients when it's happening regardless of diagnosis. Our number one diagnosis now for delayed or missed when we're not recognizing a deteriorating patient is actually respiratory failure now. It used to be sepsis, now it's respiratory failure, and some of the work that Dr. Clements will tell you about will be what has successfully gotten us to move that particular needle. But nonetheless, this is an example of a case where we didn't get it right. And one of the other things that Dr. Clements is going to mention, and I just had to pull this up because when we developed our bedside patient rescue initiative that I've spoken about before, on the hospital floor, we very specifically decided not to target sepsis because as we were doing our mortality reviews, we were recognizing that people were dying of unrecognized sepsis, unrecognized cardiogenic shock, unrecognized exsanguination, or hypovolemic shock. It was just unrecognized shock. And we didn't want to miss any of the other potential diagnoses since they were happening with enough frequency that we could actually trend them in our mortality review data. So we decided to go globally and just look for deteriorating patients. So I'm going to give you an example of this particular situation. So a 77-year-old man presented to the emergency department after a fall in the shower. He hadn't been feeling well for 2 days, loss of appetite, and vague abdominal pain. Vital signs when he came into the emergency department were pulse of 110, blood pressure of 100, respiratory rate of 24 with a fever. White count was elevated, lactate was elevated. Sepsis bundle was started appropriately, bolused IV antibiotics. He was found to have a UTI, and he improved and did well. Very successful care. Now let's change it just a little bit to somebody who is treated for sepsis. They have a UTI. They come into the hospital floor. They've stabilized them appropriately in the emergency room. They're on a general care floor. A hospitalist is taking care of them. Then they start to become delirious. They become more confused over the next 24 hours. Gosh, we recheck the lactate 2 days later, and it increased from when it had decreased initially. And he's not eating, et cetera, et cetera. And then finally, a couple days after that, when we get the CT scan, we see this, and operatively we see what's in the right lower corner. Yes, he did have a UTI, but what he also had was mesenteric ischemia, and we missed and delayed that diagnosis with just a little bit of fixation bias along the way. So what is often SIRS can often be something else as well, and I believe very strongly that those delayed or misdiagnoses, regardless of what it was, sepsis being incredibly common, are system failures where our system does not support our nurses and doctors so that they can do their best work every day. None of us come to work to miss a diagnosis like any of those I've just described. We all want to do our best job, and we need the system to support us better. That's the part of the intent of the safety learning system, the international collaborative that's been going on now for almost 18 months and growing. We believe that it is the next generation of patient safety work in the United States. And one of its main components and big pieces is moving away from peer review, so moving away from who made the mistake or what was the mistake specifically to where did the process and system fail our providers. In contrast to peer review, the safety learning system is using a approach of reviewing 100 consecutive cases of a particular cohort of interest for a hospital. It could be readmissions, it could be sepsis, it could be mortalities. Pick a cohort where your organization is trying to improve. Review and discuss those cases as a multidisciplinary, multi-specialty practicing provider team and identify all the opportunities for improvement possible. Share that learning broadly so that all of your providers can learn, not just the ones who are affected by a particular reported case, as often happens in a peer review setting. That will allow us to understand where the process and system failures are, identify those clusters where things are occurring, a delayed or misdiagnosis of sepsis on one floor, the missed opportunity to identify obstructive sleep apnea before patients undergo surgery and are using PCAs afterwards and have respiratory deaths. Those different clusters of things that you can learn from that are affecting all of your providers, not to mention your patients. In the collaborative, we're looking for opportunities for improvement, and we identify and define an opportunity for improvement by being patient advocates. And ultimately, what it's become is, what if it was your mom? And that's the bar that we set several years ago as we were debating a case around a delayed or misdiagnosis of sepsis. The patient had been hypotensive for over 4 hours, with blood pressure in the 70s, and we were debating whether or not that was an acceptable period of time, or did we call it a delayed resuscitation, a failure to rescue death? And finally, somebody in the room raised their hand. It was a nurse, and I'm sorry, I can't remember her name. I really wish I could, because I talk about her every single time I give a talk. She raised her hand and said, if that was your mom, could you have sat there and been a loved one, or would you have been up in the hallway looking for help or writing your own orders? I can tell you when my mom had her bypass surgery at Mayo, I didn't last 15 minutes with a blood pressure of 65. I couldn't last 4 hours with a blood pressure of 70, I promise. And so if we're going to be patient advocates and we set the bar, if the care isn't good enough for mom, then it's not good enough for any other patient in your hospital. And that's how we're defining opportunities for improvement in this collaborative. This is a representation of the parts of the country where people are participating, and it's a growing, incredibly amazing group of people that I've been so blessed to meet. These are the opportunities for improvement that we've identified. This is after 1 year's worth of data. There's still 2 institutions that don't have their finalized data in here, so these numbers will change a little bit. The first is the end-of-life opportunities, which is not a surprise, followed by documentation and treatment. What I'll just point out to you quickly here is that 80% of what we can do something about are not hacks or HAIs. They're all omissions or commissions. And when you look specifically at what our delayed or misdiagnoses are, number 1 is sepsis, followed by pulmonary and neurologic-related conditions. But nationally, for those who are participating in the collaborative, it is sepsis as the primary missed or delayed diagnosis that leads to death. What are the contributing factors to that? That's the other fun part about this collaborative, is getting into some of the contributing human factors that we've translated from the DoD aeronautical engineering space. One is diagnostic accuracy. That was the most common. And it was attributed to incomplete differential diagnoses and fixation bias, not unlike that mesenteric ischemia case I mentioned. The second is appropriative test ordering, which is obviously going to be related to your differential diagnosis. Gradual decline in patient conditions, making it easy for us to miss it. Can't see the trends in the EHR. The patient, quote, looks good even though some of their signals are changing. So just that gradual decline. Level of provider experience or knowledge, so not getting a specialist to the bedside, or maybe it's an intern that's taking care of the patient, followed by a delay in escalation to the appropriate level of care. Timely follow-up on labs, so UTI, the urine's been sitting there with the results showing positive for 2 days and nobody's started the antibiotics, those type of delays. And intensity of treatment not being adequate, and what we mean by that is not giving adequate oxygen replacement, IV fluid boluses, appropriate broad-spectrum antibiotics, whatever the adequate treatment would be, and the intensity just not being there. So just, for instance, somebody's got a blood pressure of 80 and they give a 200 cc bolus of fluids, and then the next set of vials is checked 8 hours later. So they knew something was up, but they just didn't quite get how sick the patient was and didn't react intensively enough. So those are some of the things, the delayed or misdiagnoses, the other opportunities that are not HACs or HAIs that are sitting under the water in this very large iceberg in the United States, and some of the contributing factors that we're beginning to find and understand and quantitate that are related to that. We invite anyone to continue to join us. We're growing. We're just going to keep growing, and the more people who participate, the more we're going to learn, and the more I think we're going to have the opportunity to change some of the dialogue that's taking place at a national basis about what we need to do in the patient safety world above and beyond HACs and HAIs. Our mission is that no one should ever suffer or die as a result of process or system failures, and I sincerely hope that you'll all consider joining us. And now I want to turn it over to Dr. Clements, who is a dynamic and amazing emergency room doctor at Mayo Clinic. When he works nights and I get a chance to work nights, that's when we get a chance to catch up and see each other. And he is a systems thinker and very passionate about improving care across hospitals and within hospitals. So, Dr. Clements, I turn it over to you.
Well, and I'll introduce him. I have Dr. Clements' bio here, so I would just like to give you a little bit of his bio. He describes himself as a recovering researcher who now works on evidence-based practice change and implementation. As the Associate Practice Chair of Emergency Medicine at Mayo, he focuses on multidisciplinary and interdepartmental improvement projects in Rochester and across the Midwest. His first love and academic focus remains sepsis, emergency infection, and critical care. And as the director of the Mayo Clinic ED Sepsis Program and primary investigator of the Mayo ED Biosepsis Biobank, he's led and participated in the last 5 improvement projects surrounding sepsis at Mayo, and he's currently working on diffusion and advocacy with national organizations to improve systems surrounding sepsis outcomes and metrics. So, Dr. Clements, we're really excited to have you speak, and I call myself a recovering optimist, but on the wagon of reality, so I can relate to your recovering researcher comment.
That's great. I really appreciate the opportunity. Thank you guys so much for the invitation. That title on that slide, I think, is Dr. Arnold's presentations, and I hope that we don't have to give his slides because I probably wouldn't do it as well as he would. As I was preparing for this, I talked to Jeanne, and we really talked about that failure to recognize sepsis part of this. And so I'm going to talk more today than I often do about how sepsis is defined and diagnosed and how we recognize it, including some outcome improvements that we've made at Mayo Clinic. I'm going to focus less so on the treatment details of sepsis as they may relate to SEP1 and the national metrics. And we can make a comment about the national metrics at the end, but I'm going to avoid getting into the nitty-gritty of the treatment recommendations, and I will show you what we do instead. I was talking to a colleague yesterday, and I said, I've given a few webinars, and I always find it disconcerting that no one's there to groan at my jokes. And they said I had a unique opportunity that I could add a laugh track. I haven't done that out of respect for you all.
I will laugh on their behalf for you.
I don't have any personal financial disclosures. However, I do work for Mayo, and Mayo benefits from some other activities that I do similar to Jeanne. I consult for the Mayo Clinic Care Network on sepsis and other implementation projects. I will not discuss any off-label uses today. Some of the screenshots I will use are from the software platforms of Aware and Yes, which were both developed and are licensed by Mayo Clinic. This is mostly EMR agnostic, and I can tell you how we're going to do this in different ways, in different places. I'll also show you no real identified patients that aren't public record. There will be a couple of names and clinic numbers in later slides. Those are from a test environment and are made up. And all copyrighted content I either have permission to use or will use under fair use for commenting on it. So I'm going to spend more time than you might have spent before in thinking about the historical context of sepsis, specifically over the last 16 years, because that tells a story and it puts into context all of the problems that we're having today related to how to identify sepsis, how to treat sepsis, and how do we come up with meaningful metrics to say that we've been good at treating sepsis or not. We're going to talk about our shock identification program, which is a multi-use tool that I helped develop, and how we manage sepsis here, not just in the ED, but in the hospital and ICU. And we're going to talk about the importance of care coordination, which was a touch point when we started to look at how things went, that we realized that we weren't coordinating as well as we could. And lastly, I'll actually share our outcome data with you. I didn't know that sepsis is now number 2 compared to respiratory failure in the mortality review, and I'll try to get my fat head out the door of my office for taking a little bit of credit for that today. So I start with a case. This is not a case that was cared for at the Mayo Clinic, but it's a public record case, which is a 20-year-old previously healthy woman. She presented to an ED in another country, actually, with colicky flank pain, and they diagnosed her clinically with a kidney stone, and she was hospitalized for pain control to be treated symptomatically in a trial of passage. 3 weeks later, she was dead after a complicated hospital course. So what happened in the interim? Well, this is Mariana Bridi Costa. Now, there's lots of different examples you could use of famous people who died of sepsis, Pope John Paul II, for example. But Mari is interesting because she's the one that you don't expect. She was healthy and she was young, and then she just died from infection. And how do we recognize this up front and learn to treat this in an appropriate way? This case came to international fame in 2009 when she died because of the unexpected nature. And during her hospital course, surgeons removed both her hands, both her feet, and half of her stomach to try to stop the necrotizing infection as it consumed her body. As a follow-up, this turned out to be a pseudomonal infection, and every time they gave an antibiotic, they didn't double cover, and it became more and more resistant, and ending up killing her. So why do we care? What should we talk about sepsis today? Why is there 3 different webinars attributed to sepsis? I know that Dr. Arnold covered this a little bit last time to say that this is the most expensive problem in healthcare. I like to use this story to actually describe that. For everyone who has an acute myocardial infarction, we spend about $11.5 billion in the United States, at least as of 2012. For everybody in the country that has a stroke, we spend about $8.3 billion. Now, if you add those two together, you're still $500 million short for what we spend on taking care of sepsis patients. Also, this is how most patients in the hospital die. You know, you can have cancer, you have then immune suppression, you develop an infection, and you die. The actual mechanism of death that you have is sepsis, and that sepsis is the syndrome, the constellation of signs and symptoms that kill you, where your underlying problem is still cancer. You still have to treat both problems. This is data from Kaiser Permanente as well as the National Inpatient Sample, which involves millions and millions of patients, and I can't imagine having to go through 143,000 charts to review to see if which ones were sepsis and which ones weren't, but they did that, and we know that the majority of patients dying in our hospitals are dying of sepsis. This is not a new problem to recognize. Everybody knows that early recognition is key to identifying sepsis and then to starting the treatment pathways that will help it. In Machiavelli's The Prince, Book 3, he actually said a hectic fever is easy to treat early on, but if you miss it, it becomes much more difficult to treat. So where did we start with this? In 1991, there is a pulmonologist and critical care doctor named Richard Bone who got his colleagues together and said, most of our patients in the ICUs are dying of these infections. Can we get together and agree on what this is and start to think about what to do with it? And essentially, the American Academy of Chest Physicians and the Society for Critical Care Medicine had a conference where they defined the sepsis syndrome. They came up with nomenclature to describe it. They said, you don't have to know where the infection is for someone to die of that infection, so that's not a requirement. And then they called for illness severity scoring systems. Apache 1 already existed, but many of these others come as a direct result of that consensus, including SOFA, which we'll talk about later. So they described what they called the systemic inflammatory response syndrome. And this was intended to be highly sensitive for identifying patients with systemic illness that may be due to infection or other causes. And so any dysregulation in homeostasis will cause your heart rate to go up a little bit, your respirations to go up a little bit, your temperature may be high or low, and you may have a white blood cell count or not. And again, that was intended not to miss people. I think if you look at these and think about walking up 3 flights of stairs on your way into work this morning, you had SIRS because your respirations were likely slightly elevated and your heart rate was up. That doesn't mean that you were critically ill. This was a screening tool. Unfortunately, it's not the best screening tool, and we'll kind of talk about why. I will tell you a little bit of our own data. In running the sepsis biobank here, we looked for SIRS criteria among other indicators that would suggest sepsis to come up with sort of matched patients who displayed critical illness. And most of these things are actually more abnormal in non-infected individuals than infected individuals, with the exception of body temperature. White blood cell count included, which I think surprises a lot of people. And we will talk about SIRS because it continues to be important for national metrics, but it's not really how we define sepsis anymore. So sepsis up until 2016 was defined as SIRS criteria plus a suspected infection, and then as Dr. Arnold spoke about last time, there's a continuity of illness that as you develop more and more severe infection, that turns into severe sepsis once you have organ dysfunction, and then shock when you have persistent hypotension. SIRS is absolutely not all infection, which would be sepsis, but things like trauma, burns, ischemia, hemorrhage, they can all cause this SIRS syndrome as well. So identifying the infection is a key point. Here's an illustration of why it was a problem as we've used this for 15 years and continue to use this in my department. It's been said that 100% of post-operative patients in a surgical ICU have SIRS at some point during their ICU stay. 2 SIRS criteria. In this one, in a medical ICU, 68% of patients had SIRS, whereas only a quarter of those had an infection to indicate that it was sepsis. And then of the patients that had SIRS, only about 1 in 5 would progress to severe sepsis, and only 1 in about 20 or 25 would develop septic shock. This is important because we have to treat these things differently, and I want you to start thinking about what do we do differently with the information that we have in order to affect the patient, as opposed to just noticing that the patient has something different. Then, a couple of years ago in 2015, it came out that what we've been describing as a sensitive screening tool for some time turns out probably not to be so much. In retrospective review, patients who had bad and difficult outcomes from infections, about 12% of them don't have 2 SIRS criteria, and several don't even have 1. And so if we're missing patients that we need to intervene on, that would also indicate the call for a new system of definition and identification. So as the bone criteria from the early 90s came into effect and we started to look at how do we come up with illness prediction scoring, really the most landmark paper in sepsis that everyone will continue to cite is Manny Rivers' study on early goal-directed therapy. This was a bundle of care which was relatively complicated, but was really the first intervention to change mortality more than just a single-digit couple of percent. Whereas he had pretty sick patients and their mortality was 46.5%, and with the folks that got this complicated bundle, it dropped significantly to 30%. I know that you all know of this study, or many of you do, and many of you know of the recent press and comparison studies about that. I'm going to help put those into a little bit of context, I hope. This helped, now that there was an intervention that might help, this really sparked the the creation of the Surviving Sepsis campaign. In 2002, 3 different organizations, the Society for Critical Care Medicine, European Society for Intensive Care, and the International Sepsis Forum, got together to make the Surviving Sepsis campaign. I would like to point out here that those are all critical care organizations with the exception of the International Sepsis Forum, because traditionally the sepsis was an ICU problem because that's where they all ended up. And so the initial recognition of that problem was in the ICU. Now we're noticing that early and earlier treatment is important, and I would say that other expertise is needed. In October, they drafted the Barcelona Declaration and set very lofty goals for themselves to reduce sepsis mortality 25%, and that's mostly based a lot on the early goal-directed therapy findings. And they recommended a clearer definition of sepsis than SIRS plus infection plus organ dysfunction, and consistent treatment protocols, really operationalization of the early goal-directed therapy. Well, they went back to Dr. Bone, and they said, can you please help clarify the diagnosis of sepsis? Really what we're having problems with is how do we define end organ dysfunction, and we want that in a measurable way. Now, you and I and many people on this phone call are quality people, and we love metrics and we love data. Unfortunately, sometimes that means that we make things overly complicated. And this is what happened. So this is the longest and most tested sepsis definition that we have, and it existed from 2003 until January of 2016. And really, there's no way that you can hold people accountable for missing or making a sepsis diagnosis when you start to look at some of these things. So, for example, if you have an infection, a fever, and appropriate heart rate for the fever, and then you notice that you have edema in the legs and an ileus, then you have severe sepsis. The problem with that is, what does that patient need? Do they need a bunch of fluid to help that, or do they need control of their infection? Well, at that point, we only had a hammer and everything is a nail, and so early goal-directed therapy would be recommended for these patients. No one knows if that's what these patients needed. In 2016, a group of ICU doctors, and I'm very specific that they're ICU doctors, released Sepsis 3.0, or the Third Consensus Conference on Sepsis. I heard about this back in 2014 at the International Sepsis Forum, and the idea of this is to make this simpler, and I think that that is a very laudable goal. So Merv Singer, the lead author on that, described it to me as sepsis is really infection with badness. He said, if you want to know what sepsis looks like, you should ask an intern in your hospital, because that's what we want to define sepsis as. And that's meant to make sense. It's hard to operationalize, but it's meant to make sense. And the intent right up front was that this should utilize some of those illness severity scoring that they've called for since 1991. And they settled on SOFA. And they said, we want this to utilize to say who's going to have a bad time with their infection. Well, the problem with SOFA is that it's an ICU-based scoring system. It requires arterial oxygen measurement, which is not routinely done in lots of places or clinically indicated apart from the SOFA score in many patients. It also includes longitudinal measurements, so how many vasopressors is someone requiring, for example, which may not be clear until many hours or even days into someone's illness course, and surrogate markers for renal dysfunction, including urine output, which we don't always have up front when the opportunity to treat sepsis presents itself. So they, as part of the Sepsis 3 definitions, worked with the Pittsburgh group to identify clinical variables that would be immediately available in an emergency department or clinical setting that didn't require laboratory measurement in order to help replace or at least immediately identify and describe the sepsis score. And they started with 7 clinical variables, whittled it down to 5, and then settled on 3 as that they felt were fairly predictive of a patient's hospital course. This is the Q-SOFA. And if you ever want to get ICU doctors and emergency doctors to have an interesting discussion with lots of loud voices, you should ask people what they think about the Q-SOFA. Essentially, it does fairly well predict patients that are going to have a hard time. If you have only one Q-SOFA score at a given time, it's likely that you'll be okay. However, it doesn't mean you won't develop more of that score later, because this is retrospectively derived from large patient cohorts. So this is really patients who never had more than one Q-SOFA point will do well. It's not the folks that are right now going to be okay because they're not going to develop further score in their later hospital course. So how useful is this to our clinical care? And I'm not sure that it's clear yet. I can tell you we don't use it. I don't use it in my emergency department. We make note of it, but we don't use it. I know that Ryan said that they kind of incorporated it into their system last month on this webinar. Part of the problem is that the ground rule that the surviving sepsis folks set when they developed this is it has to be usable anywhere. And there's a very famous sepsis doctor in Brazil, and they said she's going to need to be able to use this if she were to go to the Amazon jungle, just as we should be able to use it on the floor of New York Presbyterian Hospital. So in modern medicine, I'm not sure that that translates into a usable tool because the care and treatment in those two places is not identical. As again, I said it's retrospectively derived, which did enrich for more sick patients than we would see in an undifferentiated population, that this would have to be implemented to assess. And this is the most important point. Again, like I said earlier, I want you to start thinking about what you can do something about as opposed to just knowing that someone's going to have a problem or a change in their clinical state. This is a score for risk stratification. And what Sepsis 3 has done is it has replaced something that's used for identification or screening for sepsis vis-a-vis SIRS, and it's replaced it with a risk stratification tool which is not intended to be sensitive to identify patients who may be critically ill later. So this is not recognition. This is the sepsis criteria to put in front of you. Sepsis is infection with a SOFA that goes up by 2, and septic shock is infection that requires both vasopressors and has an elevated lactate. So the patient that you described potentially in the hospital, Dr. Huddleston, who had hypotension that was severe for 4 hours, and if they got fluid and ended up on pressors, but their lactate was normal, then they still would not be considered to have septic shock. I'm not sure that that's a clinically relevant definition. We would still treat that aggressively, I think. So again, it does improve risk stratification, which is important. We need to know what level of care and how aggressive we should be, but it compromises recognition to some degree. So that's sort of the history and the story of how we got where we are and why this is a bit of a quagmire in 2017 on how to identify and recognize sepsis. While it keeps people like me very busy with speaking engagements, it probably is not benefiting the patient all that well all the time. So the next question we're going to move on to is sort of management and treatment. To be or not to be, and that is to bundle or not bundle. This, in the last 2 months, has led to 2 very high-profile publications in JAMA and in the New England Journal, which have competing conclusions, one from New York State and one is a review of the sepsis literature. I do want to point out this is what early goal-directed therapy looks like when you have it as a bundle of care. And I think one of the most brilliant things that this did is it gave permission for people to give fluid that they would otherwise not do. I really think that was the biggest benefit of early goal-directed therapy. In 2001, if we gave an entire liter of fluid to a patient, being 1 IV bag, a lot of people would say, I can't believe you gave that patient so much fluid. Early goal-directed therapy replaced that medical decision-making part by taking volume out of it, and you treat to a CVP, which we know is actually a pretty bad measurement of intravascular volume, or not necessarily reliable. But because of that, the people would feel more comfortable with the amount of fluid that some of these patients needed, which was 4, 5, or 6 liters sometimes. Then they bundled into this a number of other measurements, including SCVO2, for example, which was controversial and no one knew if that affected the patient or not. But because it was within a bundle of care, it's very difficult to test and take out that one part of it to see how important it was. And it took us 13 more years to do that. And in 2014, there was the publication of 3 large trials, the PROCESS, ARISE, and PROMISE trials. These were independent, but they did coordinate with monthly phone calls to discuss as they went along issues that they were running into, and there were some nuanced differences. For example, the SCVO2 measurement was specifically forbidden in the ARISE trial in Australia to help assess whether or not that was useful. The ED care in the PROMISE trial is very difficult to tease out because the length of stay for patients was 1.5 days in Great Britain in the emergency department. In my department, we averaged 4 hours. So I will ask, did these trials, which are assessing early sepsis management, really test the early care that they had intended to? And the reason is this. This is from the supplemental data of the PROMISE trial, which shows that prior to randomization into the studies, these patients had received about 3 hours of care in the emergency department. And during that time, the different sites that this was being studied in were continuing to treat that patient with critical care prior to the research investigation. And before the patients ever started to get the fluid and the things that the different protocol arms would call for, they'd already received about 30 milliliters per kilogram of IV fluid in all 3 of these trials. This is PROCESS, this is ARISE, again, 35 milliliters per kilogram prior to the patients being randomized into the treatment arms. So bundle has become an incredibly loaded term. When you say bundle to a resident now, they go into cold sweats and they look like they're gonna cry sometimes because we don't know how to unbundle a bundle once we get to it. I will say that of the patients in these 3 wonderful trials that have shown vast improvements from 2001 when we started this process of sepsis treatment, I have my concerns that we still have not adequately tested the very early sepsis care on these patients. And that with the excellent care that they had already received, which I'll outline in a moment, their outcomes were probably already improved prior to the research intervention. Derek Angus, who's the primary investigator for the PROCESS trial, said once, and I love this, he said, "I wish I'd not called it usual care, because usual care in 2014 is not the same thing as usual care in 2001, which is a big highlight of these studies." And I think that this is prone to some over investigation or overthinking it, where people can think that usual care means that you can do whatever you want to care for these patients, and that is likely not true. So what happened in these 3 trials prior to their randomization in these trials? They'd already received a lactate, that's part of the protocol. They'd already had blood cultures drawn, that's part of the protocol. About 77% of them had already received broad-spectrum antibiotics. I would actually have hoped and expected that that would be higher. And then between the pre-randomization and early randomization phase, all of these patients had received really about 50 to 60 milliliters per kilogram of fluid, which is a lot of fluid. But remember that they're shock patients. And the hospital mortality in PROCESS, and very similarly in the other 2 trials, was less than 20%. Remember that where we started this in 2001, there was 46.5%. And so people have thought about this and said, were these patients less sick? I don't think that that's the answer. I think that these patients had already been treated. I will tell you that sepsis bundle interventions over the last 15 years have improved mortality in almost every case when they've been studied. This is not the same thing as looking at early goal-directed care versus protocolized management versus, quote, usual, unquote, care. This is if we make a concerted effort to improve sepsis management by helping our clinicians with a set of interventions that will improve sepsis outcomes, those work. And this slide in this paper from CHEST can help highlight that for you. I will tell you that overall, mortality has also continued to improve to a degree up over time. Again, with a baseline of 45 some odd percent, we have sepsis mortality of less than 30% in this country now. That has sort of slowed down on its improvements, and I'll be interested to see what it does in the next several years as we've changed the rules and continue to change the metrics. Here's what I want you to know, which is why I put a big gold star on here. I have 3 daughters, and we have to put a gold star when we want them to pay attention. guiding principles of sepsis care, I think, is a better terminology than talking about a bundle. And I think that if everybody treats sepsis patients with these 3 guiding principles of sepsis care, this will save lives, and it's much more simple than think of that flowchart with early goal-directed therapy. Please identify infected patients who are getting sick early as possible, and that can be done in different ways. I'll tell you how we did it. Secondly, you should give antibiotics once you suspect that infection as very quickly as possible, and if it's something that requires a procedure or other control of that infected space, we should involve those specialties immediately. And thirdly, there has to be IV fluid once you have critical illness, because we know in multiple different ways this maintains blood flow to the vital organs. There you go. That's how to manage sepsis. And it's not a bundle, but it can be turned into one that fits your practice style at your institution. At Mayo, we sat down, and this was actually before publication of Process, Arise, and Promise, and we agreed to a simplified bundle because we didn't believe that SCVO2 or transfusion to a hemoglobin of 10, both of which are required in early goal-directed therapy, was either reasonable or had beneficial effects on patient outcomes. And so we felt like we were big rebels at that time because we were doing something different than they had done anywhere else in the country. And it was before these trials came out, and we were very pleased once they were published and accidentally agreed with us. So here we have asked our providers to get a lactate within 1 hour of the order of a blood culture if they're suspecting critical illness, to draw blood cultures before giving antibiotics, and we set the lofty goal of giving antibiotics within 1 hour of the onset of severe illness. And then for fluids, we felt that the actionable interaction was when blood pressure dropped or lactate was resulted at greater than 4. Because if someone isn't hypotensive or doesn't have a lactate of 4 or more, we don't know how much fluid they need, because every intervention has always had those 2 things as the input. It doesn't say you shouldn't or can't give fluid to people before that happens, but once it happens, we're going to hold you to that volume expectation. However, we didn't know, there was a lot of discussion over whether that would harm some patients, and so we left an out for our providers, and we said, you can certainly give less fluid if you think that's clinically indicated, but please document your reasoning, and we're going to follow this. We also measure other secondary outcomes other than just the fluid, antibiotics, lactate, and blood cultures, time to blood pressure normalization and time to lactate normalization. Those are local metrics, and I don't know of other places that are doing that the same way. The evidence between the 1 hour window for antibiotic timing is hotly contested in different organizations. I very much respect Alan Jones and Mike Puskrich, my colleagues in Mississippi, who feel that in some cases we can wait a little bit longer to give antibiotics. But I think there's at least moderate evidence that the earlier we give antibiotics, the better patients do. This is one study from 2006. It's the one that's always cited because it found the biggest difference. It says that it's almost 8% increase in absolute mortality for every antibiotic, or every hour that antibiotic is delayed. So if you get it in the first hour, about 83% of those patients survived. If it's within 30 minutes, within 30 minutes is 83%, and within an hour, 78%. So it's the same idea of trauma of having a golden hour of opportunity to intervene. And if you waited until the 6th hour, there was a 42% mortality, which is, remember, where we started in 2001. That sounded like that was a long, long time to wait for antibiotics. But as Jeanne just sort of laid out, how long is a long time as these things are going on? I was surprised to learn that the median time of intervention for their study was 6 hours. This has been confirmed in other more recent publications that the timing of antibiotics remains important and I think a crucial step in the management of sepsis. I'm trying to go forward here. Hold on. Okay, there we go. So, and then I did want to talk just for a minute briefly about fluid management and how much fluid. I'm throwing around numbers that make Europeans cringe because they use less fluid per kilogram than we would often recommend. And part of that reason is the coordination of care in the different places that patients are receiving care. They don't always know what is happening in other places, and so when the ICU folks would recommend a 10 milliliter per kilo bolus in Europe, which is not uncommon, the patient may have received more in other places already. So how much fluid does the patient need? And the answer is enough. We have to maintain that blood flow to the vital organs. prior to 2001, we didn't give enough volume, and that was one of the main benefits of early goal-directed therapy. And oftentimes, patients in true septic shock need quite a lot of fluid that many people are uncomfortable with. So in 2012, the Surviving Sepsis campaigns did change their guidelines from 20 milliliters per kilogram to 30 based on outcomes data, which was evidence-based. And so most places do somewhere between that. I do believe in weight-based intervention for fluids and sepsis. I know that Dr. Arnold last week talked in their system, they give 2 liters, which is a volume-based intervention. Sometimes we have patients who are very cachectic and may weigh 40 kilograms. That would be a lot of fluid for them. And sometimes we have the larger folks that require significantly more. I'm 6 foot 4.5 inches tall, and I have family members in the NFL, and I would need more than the 2 liters. So I also would like to point out that a bolus is not over hours, while the national metrics currently say we have 3 hours to get our fluid in for some of these things. We here shoot for a rate of a liter every 15 to 30 minutes. This is worrisome to some people at first until you get used to it, and once you get used to it, you realize that patients actually do quite well with that. When we started our intervention to recommend this fluid up front and fast, we had a lot of people say, well, you're going to have to intubate folks, and we said, yeah, we will expect that. And we were very surprised to realize that we don't actually, because they need this fluid. And I can't remember the last patient that got intubated for fluid overload for sepsis treatment in our emergency department, and we give significant amounts of fluid. There is some outcomes data, but again, you have to take this with a grain of salt because where are you measuring this fluid? Where is it charted? And are you capturing everything that the patient got all the way from healthcare point of contact through to the ICU? And there seems to be a bit of a sweet spot somewhere around 30 milliliters per kilogram, but patients with persistent shock can sometimes require more based on bedside assessments. You can see that if you give too little, the patients die, and if you give too much, the patients die. So I want to talk about how we at Mayo have tried to improve our recognition. And it really comes down to this. We have some of the most complex screening mechanisms for sepsis ever developed. We've developed them in the ICU. We developed them in our emergency department. They've been published on. And it turns out that there's always a lot of noise, because those things continue to go off, and alarm fatigue is a real thing. When Dr. Arnold last month talked about the sepsis alert, I looked at some of those things and I thought, I wonder how much of that adds value to the patient care, and sometimes. The other thing is that this automated recognition leads to overtreatment. And so if you have a sepsis alert going off over and over and over and over, you may end up giving the pancreatitis patient a significant amount of fluid that is not the best in their best interest. And over time, it leads to lack of trust. I can tell you we still do run a sepsis screen in the background that oftentimes is completely ignored by our providers because we've used it for years and it doesn't seem to add value to what we do differently for the patient. So and what do we do with the result? So what I did when we started the most recent intervention is we went to our practices. We went to the ICU practice, to the medicine practice, and to the ED practice. And we said, really, we need to find common ground. What can we all agree on that we should do? What's the low-hanging fruit here? And they said, well, absolutely, shock needs treatment. And so I said, what is shock? And they said, well, it's really hypotension or lactate, which is the fluid issue. And I said, which patients? Because is this just sepsis, or is there other shock states that you need to know about as well? And they said, we want to know about all of them. And I said, well, okay, what would be value added if there's going to be an alert? And they said we would like, and the different answers were they wanted evidence-based decision support, coordination of care, and feedback mechanisms which were not judgmental. So I asked the question, and this was a crucial conversations kind of moment. If I can offer these things, can I put a single manual step into your workflow? Would that add value, or would blocking that be a problem? And they said, sure. Which is, some of them may regret that, but I think it's gone well. And I built the first ever absolutely obtrusive, annoying alarm. The idea is the ability to continue their workflow until they interact with it. And this is the ICU and the ED. It's going to be specific. It's only going to go off when you have a confirmed low blood pressure or a lactate result greater than 4, and it will then require your interaction to proceed. This is a screenshot of our YES tracking board, and you can see this is how providers interact with a lot of information. This is how they get their vitals, look at the medications, look at lab and radiology results. Except if you have hypotension or a lactate greater than 4, then it turns into a large, annoying, flashing red siren. And they can't interact with it or do anything about it until they answer a question. What do you think is causing this shock state? Do you think it's sepsis? Do you think it's dehydration? And there are different answers for hypotension on the left and elevated lactate on the right. This is an incomplete list, and there's some things that I had wished I had added that I didn't know were causes of these states. I wish that I'd added medication effect under the hypotension part, because that's the most common other answer that's given. We give medicines that drop blood pressure a little bit. And I wish that we've added blunt trauma or seizure to the elevated lactate, because while I thought through that hemorrhage would probably find that it's not necessarily always hemorrhage and blunt trauma, and seizure is a frequent cause of elevated lactates. You can say, ask again in 15 minutes so that you can get back to your workflow, but you're thinking about it, at which point the siren turns blue and goes down into the corner, and then 15 minutes later it becomes the big red annoying block again. So Merksinger said that sepsis is infection with badness. I essentially took that and turned it around, and I said, okay, now we've got badness. Is there infection? And instead of using complex algorithms for vital signs and lab results, we're using the human brain as the computer, but we're making them ask themselves that question. And I'll tell you how well that's working in a minute. Once you click that you think that it's sepsis, you're offered decision support with your ordering. It brings up our laboratory ordering and capabilities for getting urine and chest x-rays and the like. And then throughout the time of your resuscitation, there's a tracking board. That tracking board in the upper left-hand corner has our 4-element bundle that we expect people to do, and these turn from red to green as they've been completed. And then at the chart on the bottom, you can actually see when the antibiotics are being infused. You can trend the lactate results, which is the red line up above. You can track fluid, which is the area under the curve at the bottom. And then you can actually see culture results as well, as that E. coli flag says is one of the cultures, sterile site cultures, grew out a bug that we know we need to intervene on. This persists through the patient's stay in the hospital. And so on the left, or at the very top of the chart, you'll see a red bar. That's when they're in the ED. And then it turns blue and it says MB6B. That's the unit that the patient went to. And the screen that we're looking at in the ED is the exact same screen that they're looking at in the ICU. We also have a simple 4-box system. When you mouse over the patient on the YES board, those turns from red to green as you're accomplishing your goals with the simplified sepsis bundle. This allows us to do longitudinal tracking and reporting. I get emails and follow on every single sepsis patient that comes through the system in the ICU and the ED. And we actually provided these metrics to our providers as part of their annual review with the chair as a clinically oriented outcome. Here's how you're doing on your sepsis resuscitations. Here's how the patients are doing, and here's how often you're interacting and getting correct with the interaction of the shock trigger. We also, as I said, this is the same screen that they see in the ICU as we see in the ED. This turned out to be a much more important part of the intervention than I expected. We had, when we started this and we started looking at how orders were done, people would come to the ED and they would have blood cultures ordered, a lactate drawn, antibiotics administered, and they were given a fluid bolus. And then they would go up to the ICU and they would have blood cultures ordered, a lactate drawn, antibiotics administered, and a fluid bolus. And there was great duplication of efforts, and it's unclear whether that was good or bad for the patient. We've developed a culture of feedback at Mayo. This really stems from a lot of work in acute myocardial infarction and stroke, where about a day after we have a STEMI patient or a stroke patient, we get an email that says, hey, thank you very much. Here are your metrics. And we did that again with sepsis. When you interact with that tool and you say severe sepsis, there's an automated email 36 hours later that our providers get that doesn't tell them that they ever did anything wrong. It says, thank you very much. We know our system is imperfect. Here's your resuscitation. Again, thank you. We're all very competitive people, and my chair will send me an email 5 minutes afterwards if there's a red box here instead of a green box. And so I don't have to tell people do it differently, do it better, don't miss it. They're going to do it better next time as well. So how is it going? We really carefully measure our metrics, at least I do because I'm based in the emergency department, from the ED to the ICU. We track outcomes but not metrics the same way for patients that go to the ED to the hospital floor. And then patients that are in the hospital that end up in an ICU level care, we're still developing systems to help track those. But for patients who are in the ED that go to the medical ICU, we're 100% compliant with lactate, and we're well over 90% with all 4 elements of the bundle individually, and 86% compliant with having all 4 of them done. We also rapidly improve blood pressure and lactate. ED providers, it turns out, are very good at recognizing sepsis or infection as the cause of shock states. We did a careful review of several hundred patients to look at how accurate folks were based both on discharge diagnosis, culture results, and independent review of those charts. And this is being written up for publication currently. But we're accurate 82% of the time, and we identify non-sepsis causes as 85% of the time. I was actually pretty pleased and surprised at that. I figured we'd call everything sepsis, and it turns out not to be the case. This is, I think, highly beneficial to that early recognition system. Our mortality varies month to month between 4 and 8%, and we have a volume of about 860 sepsis patients a year. Now, I want to make sure that I'm not overstating our results, because I don't think that you can compare this to anything else. There's no apples-to-apples comparison. We know severe sepsis and shock mortality is the 18.9% in process. Those were shock patients. These are not all shock patients. Many of them respond to that early fluids and then don't progress to shock. We also don't have good research comparison for that early care of sepsis in emergency department or on the hospital floor before ICUs and critical care are involved. When we started this, everybody thought that all of our sepsis patients went to the ICU, and it turns out that less than half of them do because we stabilize them on the floor and they don't need that anymore. But these are true patients with confirmed low blood pressure or a lactate greater than 4 have a mortality of less than 8% in Mayo Clinic, Rochester, from the ED to the hospital or ICU. Our length of stay has decreased by about a day with this intervention compared to 2012 baseline, and that has saved an awfully lot of money for the institution and for patients, and has translated into lives saved. Our ICU has now adopted this system. They've gotten rid of their screening algorithm, which was probably the best one available, and they've gone to the same idea of a multi-use shock trigger. And all of the 23 Mayo Clinic Health System EDs are implementing this in various ways, which starts in 2.5 weeks in northwest Wisconsin. And so I'm excited to see improvements as we go along. Future directions with that, because it is a multi-use shock trigger, we can offer that same level of clinical decision support and continuity of care for hemorrhage patients and for coma patients and for other things that cause any significant shock. This is not just a sepsis intervention, which I think is nice right from the get-go. Conclusions. The sepsis syndrome is really not defined to really facilitate the early care that is needed to save lives. It can be treated, and I urge you to review and remember and get tattoos of the 3 guiding principles for sepsis management, because I think that if we could do that more regularly early in illness, people wouldn't progress to their shock states. Screening for sepsis is incredibly frustrating. I'm guessing that almost every healthcare organization on this phone call has some sort of a screening system for sepsis. And I think it's interesting that our hospital has now gone away from that and gone to actionable clinical data. We can agree that we have to treat once something happens. Before that happens, you also need to treat but we don't know how. So give antibiotics, get blood cultures, check lactate, make sure that they're not sick, and then give some fluid maybe. But I'm not going to tell you how much, and I'm not going to go there. And if you add a step to patient's manual workflow, I'd encourage you to make sure that it adds value, and I would start by talking to patients and providers and nursing teams about what would add value to them. And to simplify whenever possible. This is a little bit different talk than Dr. Arnold gave last week. I adore him, and I adore all of our quality work. The issue is that we have a habit, particularly in research, of making things complicated by adding lots of variables and metrics, and that's reasonable for research. Because in research, you want to make sure that you're identifying differences and not missing differences that are important. Once we step out of that research realm and into the implementation and diffusion realm, I think that we do too many metrics, and we need to define success more clearly up front and make it 2 or 3 or 4 metrics that we're going to track. And I hope you can see that the system that we've built was made simple, more simple than otherwise would be at multiple points. I didn't do any of this stuff alone, and I would not even begin to take credit for that. This was a huge concerted effort that was made capable by the Mayo Clinic enterprise practice, saying that they wanted to tackle sepsis as a management to value sort of intervention, and I was lucky to partake in that. And I will be happy to answer any questions that you all have. Again, I really appreciate the invitation. It's been a great honor to speak to all of you today.
Great, Casey. Thank you so much. Wow, you just did such a terrific job, and as somebody with a PhD and researcher, you were so clear and communicative. It was fantastic. I'd like to turn to Dr. Greg Boats, who's on our reactor panel. He's covering ICU today. Greg, are you with us?
I'm here, Chuck.
Good. So Greg is really the great visionary behind the Care Huddle, which is a checklist for our MedTech program, and it was because of Greg that we have a MedTech program, and he's our lead faculty member. And so 2 questions to you, Greg, and we'd also like to direct people to fill in questions in the lower right-hand quadrant of your screen, and then I'll read off those questions as well. But we'll start with Greg, and then we'll go to Dan and go to Jeanne, and then we'll go through the questions. But Greg, two things. We want you to comment on what you've heard as a critical care doctor, and then also just give us your take on this issue we mentioned regarding the fentanyl and opioid overdoses. But maybe I'll come back to you at the end so we can just stay on Casey's topic and then give you the last word on that. So Greg is a professor in the Department of Critical Care at UTMD Anderson. He received his medical degree at George Washington University, full professor there at Anderson, but he's also done a medical simulation fellowship at Stanford with Dr. Gaba, and he is also the medical director of the University of Texas Police Force, which actually cares for not only Anderson but the UT Health and University of Texas in Houston. And so he has been a real champion of helping us over the last few years really make these presentations practical and relevant. And so, Greg, we'll come back to you on that separate issue regarding the opioids and MedTech and ask you to respond to what you heard Casey and Jeanne address.
Well, I really want to thank Dr. Clements for such a fantastic presentation on the issue of sepsis in our healthcare system. It rings true with all that I've been doing over the last 20 years or so in critical care and dealing with patients with sepsis. I have to admit that in my early career, before we had such attention to sepsis as an entity and some of the early work on detection and action, I just admired a lot of people with sepsis. There wasn't a lot I could do to reverse the organ system dysfunction that was present. I sort of had to support them with life support and hope that we would see improvement in the multiple organ system dysfunction that was well established by the time the patient got to the ICU. I think what we're talking about in this work and in the patient safety work is we're trying to ingrain sepsis behaviors in our teams and in our practitioners. Moving upstream to early detection is the key to try to avoid the organ system dysfunction that is so hard to treat and so hard to reverse. I think that the work that Roger Bone and others did on behalf of the societies to define what sepsis really looked like was a very difficult exercise, but at least we were looking at the signs and symptoms to help our practitioners detect patients with sepsis, with early sepsis, because you can imagine in a busy service where you have either a nursing staff taking care of multiple patients or a team taking care of multiple patients, all of our patients are sick. And to be able to see the signal to noise of the patient who's subtly changing in vital signs and in laboratory studies to say this is the person who's going to progress to sepsis was incredibly difficult. Manny River's study, I think, helped us to go from detection to action. Even though some of the activities or the action points in his protocol have been shown to be, not so helpful anymore, or maybe not the thing that everybody would do for every patient, it at least turned knowledge into action, which I think was so necessary in the early detection of sepsis. Scoring systems, the same thing. It helps us to identify our at-risk patients. I agree with you. Bundles are very, very difficult, and they've taken a big hit. But I will tell you that the bundle becomes our decision support tool. We don't have to pick everything, but at least we're thinking about elements, and we're not missing things that are very timely. Antibiotic time is very important, and picking the right antibiotic first has been shown to be very important in the treatment of sepsis. I agree that the issues with how much fluid to give has been a very contentious issue, especially recently. We often see people that come to the ICU after being treated for early sepsis, and it's more like a near drowning when they get to us. Now, we don't intubate a lot of people that have been resuscitated with a lot of fluid for septic shock, but some people with other organ system dysfunction may not respond the same way that a young and healthy person with an infection might. This was a fantastic talk. I think that it's very appropriate for our patient safety folks to learn and understand, and I love the simplification that you've done in your process here. It doesn't matter which of the 33 different items on the list that characterize sepsis are positive or not. Identifying the indicators early, treating early, and following the patient and giving them the appropriate care is really what we should be doing, and let the people use their decision support to make the right choices for the patient based on what they see in front of them. This was fantastic work, and I look forward to seeing your results as you move forward in this process.
Thank you so much, Greg, and it's always very thoughtful reactions. Before we go to Dan, I just want to have you look at your screen and see the questions that we're going to ask about it. Again, I'm going to come back to Greg regarding the opioid issues and MedTech, but the first question is, I'm interested in more detail on opioid OD and drug diversion, because it's not only those we serve, but those who serve that are at enormous risk, and the topics that you'd like us to address on the overdose and the drug diversion issues, which we know is a big problem. The second set of questions are, I'm interested in more detail regarding sepsis. It's okay if we add a number 4 part to this, if there are topics that you all really want us to address. We've had a great response today, and we've got some good questions we'll come to in a minute that I'll finish up with after we get comments from both Dan and Jeanne. But specific topics you'd like us to address are on slide 117, and Kyle has put up the questionnaire for you. So free text entry really, really helps us, because then we can hone in on what we can ask speakers to cover. And then the final questions of free text entry on the sepsis series after we complete it. After we complete it, even if we add a part 4, what future new webinar topics do you want us to address? I think Jeanne has really addressed a lot of these opportunities for improvement in omission that are enormous that we haven't been tackling, but there may be others. And if you've got a passion project that is absolutely critical, we'd like to hear about it. Dan, your comments, and then we'll go to Jeanne, and then we'll come back to Greg. Jeanne, are you still with us?
Thanks, Chuck. I'm here. Can you hear me?
Yes. And is Jeanne with us?
Yes, I am.
Yeah, good. Okay, Dan first, and then Jeanne.
Yeah, sure. Just a couple of comments. One is, and these have been very, very good and to the point presentations. Seems to me we need much intentional publicity about the serious nature of sepsis, and we need to educate the public about the early symptoms that lead to sepsis and what to do about it. Opioids are getting a lot more publicity in terms of the serious nature of the opioid crisis, and I think we need the same thing here. Secondly, it seems like there's an active role for patient advocates, family members in dealing with this subject, for example, in sharing related stories, asking tough questions. In my own role and a number of my own colleagues who are patient safety advocates, none of us get a paycheck from the organizations in which we serve, for example, in patient advisory councils. We can ask tough questions. And sometimes egos and power gradients get in the way for people working for organizations. A third point related to the first one, that seems to me the public needs to be actively involved in the research, public awareness, and ideas for change. Sometimes constructive ideas can come from the most unlikely sources. The only other point here is a question, if we don't have time to answer it, but I mean, it's from Steve, or from Jeanne and from Casey, as to the barriers to reducing sepsis, what keeps them awake, and what frustrates you about this.
Great, and Casey, I think we'll have a minute to come back to you. Jeanne, any other comments that you'd like to give? Thank you very much for your very insightful introduction.
No other comments. I just saw there was a question about joining the collaborative. Feel free to email me, and happy to move forward from there. I just want to thank Casey for his work, and I saw there's some great questions, so I'm going to shut up.
Okay, and we'll post on the website, and we may even send out the invitations to the collaborative. We think it's a terrific program. Before we go to Greg, because we've got about 4 or 5 minutes. Casey, if you could look at the lower right quadrant there, we've got to have a number of questions that we had. One person missed the computer systems that you're using at Mayo. Another was, is there a standardized class for identification of the deteriorating patient? And then comment on the education with MDs and how they have reacted to the emails and impact on care. And you can see that from Kimberly Turnavant.
Sure. So lots of places to start there. The first one I guess I should start with is the reaction to emails. I will try and go backwards in those questions a little bit. The emails are not, we're used to getting them. We have a culture of feedback. So in general, people were not upset about getting the emails. The things that we get comments on and the discussion that it has is when, the system doesn't work. So they'll say, I gave an antibiotic, here's the time of the order. And I go, okay, something broke. We'll look back at the system and figure out what wasn't going right with identifying that antibiotic. Or they say, I'm frustrated because this box is red and they had already gotten all this fluid in the ambulance. And we don't pick up the ambulance currently of how much fluid they get there. And so we give them a little thumbs up tool there so they can say, I think I made this, and you can just click the box and then the quality nurses can review it. So it's not been a problem. We're not oppositional to it. I think everybody's been really, really supportive, at least when they talk to me about it. But I think they would tell me if they didn't like it. I did see, let's see, what were some of the other questions that you asked? So the computer systems, Aware and Yes are the two homegrown computer systems. However, this is really EMR agnostic, and so we've developed we have the ideas of building an app that would pull from things like Cerner, and we have built this into our Epic implementation. And so it can work in different things. We're going to use a BPA-based system in Epic as the Mayo Clinic Enterprise moves towards Epic.
And one question was regarding any trials. This was from Alexei Ignatov about vitamin C administration for septic shock.
That's a great question. This is one of those things that came up with the folks in Western Virginia. I think that the results that they talked about from the preliminary trial were very exciting to a lot of folks. I don't think that the mechanism necessarily makes sense. I would direct folks to some of the reviews of that style. There's a great one from Skeptic's Guide to Emergency Medicine, and there's some others that are mostly podcast-based that can discuss that in more detail. We don't do that here right now.
Great. And we've got other questions, but we know that many people have to go back to clinical duties, and we always get feedback we want to finish on time. So
can I answer one more question that I saw pop up there? It'll take me honestly 2 minutes or less.
Yeah, go for it.
They said, what do you do with end-stage renal disease patients regarding fluids? And while metrics-wise we give providers the out if they can document that they're concerned about that, there's almost no evidence for end-stage renal disease. I know of 2 published abstracts in which they look at folks who are with ESRD, and they found that if they don't get the fluid, they generally did worse than if they did get the fluid. Secondly is CHF patients, which you didn't ask about, but is another sort of special population that's much more common. I've actually researched that here. We've done 205 consecutive patients with and without CHF, and with the folks that got the fluid versus didn't get 30 cc's per kilo, we had no difference in respiratory failure, need for intubation, or non-invasive ventilation. And so generally it's something to think about, but I wouldn't overthink it.
Great. Thank you so much. And so we'll go just a minute or two over and have Greg address this crisis, this opioid crisis, fentanyl, carfentanil sort of issue, because it is just such a crisis. We've got morgues that are overflowing with patients that even can't take any more bodies, and they've just, especially in Ohio, it's just a crisis. So, Greg, do you want to give us just a quick update there? Greg also works with the DEA and has some great insights on this growing crisis.
Well, I think everybody currently sees the information in the media about the epidemic of opiates in our communities and the tremendous impact it's having with overdose deaths. And I think a lot of those are affecting our communities. We've even seen articles in the media recently where churches are handing out Narcan to their parishioners or to their members to take the advanced step of acknowledging that it's a problem and trying to treat them before we lose more of our loved ones. The reality is an opiate overdose is not a lethal event. It's a preventable death if you can recognize it and intervene. The death from an opiate overdose is a hypoxic death from not breathing. And so we're trying to look at behaviors that we can impart on community members, including kids, to recognize the signs and symptoms of an opiate overdose, and if safe, intervene to try to save that person's life. And that includes providing, or first of all, getting help on the way by activating the 911 system, but there are some simple interventions like providing rescue breathing, especially if it's a family member or a loved one, to provide support until the EMS providers can get there and do more advanced skills. The ability to get Narcan in the community from pharmacies for people at risk or for family members of people at risk so that they can save them is an important intervention. We talked recently on one of these webinars about the University of Texas student governance asking the university leadership to provide Narcan to the university police and to the dormitory RAs because there's such a problem with opiate use, and they're seeing that their friends are overdosing or even dying from opiate overdoses. This is a huge problem that is a serious threat to our population. We have to do things to discourage and treat people who are using opiates, but we also have to have a plan in place to rescue them when they get sort of to the boom part of their addiction or their drug use. So that's what we're trying to focus on is identification and changing people's behaviors and imparting them with skills so they can help save someone from a very preventable death.
Great. Thank you, Greg. Really appreciate that quick update. I'd just love to thank Jeanne for your just steadfast support and championship of the mortality reviews and the great learning. And Dr. Clements, thank you so much for just such a practical and relevant presentation. And Greg, as always, you've led us to develop the MedTech program, and we're so grateful for your dedication to patients and to kids doing this. I'm going to ask Dan to close us, as we always do with our patient advocates. And God bless you all, and we hope you have a great day. And if the speakers could stay on just so we could do a quick process improvement loop. I noticed a little bit of an audio glitch and a couple of other things I know we can kind of work on. So, Dan, Dan, would you please close us? And if the speakers could just stay on for just a couple minutes so we can keep improving on what we're doing. And thank you all. God bless.
Yes, I'd echo what you just said, Chuck, in terms of the quality of this webinar today. Just absolutely outstanding. I have only one further comment, and that is just to plant this seed that Jeanne mentioned from the nurse that made the suggestion, that is, what if this were your mom? Have a great day, everybody.
Take care. Thanks, Dan. Thank you all, and we'll see you with Sepsis Part 3 next month.